Good. We talked about patient satisfaction this morning. Everybody is doing very good, and thank you. It's very important. Kim, the new patient satisfaction director, is very helpful, and she's still learning, but she's got a lot of good ideas, and that's helping a lot. I'm very happy that we got her going, because it's the kind of thing that as I said this morning, it requires care and feeding, because the front desk there's front desk turnover, there's nursing turnover, there's physician turnover, there's those things are important to kind of keep up with. And we really want to do a good job all along the line. And I have a few kind of general comments for the good of the chapter, no specific big theme, but then I would like to have the opportunity to talk with you all and answer questions you might have about how things are going, what's the future, that kind of thing. But I'll start off with, indeed, the patient SAT is an example of, we've always kind of had a culture of attempt to continuously improve things. And this morning, the better use and when to use the IVC filters. That's been an evolving story. And conference itself surrounds the concept that the way we're doing it one day may be improved, and let's do it the better way when we can. The patient SAT is like that. If we continue to try to improve on patient SAT, then that's better than care and feeding. And we're running, an aggregate scores 94 to 96. That's really pretty good. Of course, we hear about the ones where we drop the ball, and every one of those is an opportunity. And Kelly Waltrip and I review monthly every single complaint from a patient, and a lot of them, we categorize as they're misses, but they're not big misses, and we drop the ball a little bit, but some of them are opportunities, and we work on those. And the truth is, when we find these opportunities, or we lapsed in a specific case that led to a specific patient complaint, then in the past, there wasn't always feedback given to the people involved, but now we give feedback. And you guys may not have gotten any feedback because you haven't had any bad cases, but that's a great thing. And if you get some feedback, it may be an opportunity to improve, and that's important. And they're not gotchas; they're just life goes on, and some of them are really odd. I can tell you, but they don't all require action. Or some of them are just. Life happens, and some of them we can't necessarily improve. But some of the things we're working on with some of the physician partners about patient satisfaction have to do with, I won't name the physicians we're coaching on these issues, but it's really more than one. It's inherent with people who are type A. Sometimes what they say gets ahead of their thoughts. And sometimes that's worse, tired post-call. And that can cause spiraling situations. And one of the things that I've been trying to improve by coaching, focusing predominantly on the low-performing patient physicians on the patient SAT, for example, which is where the meat of improvement is, obviously. We're not going to spend a lot of extra time trying to improve somebody's patient SAT if they're already at 95 percentile, but your improvement, proportional improvement is going to come with people in the bottom third, statistically, of course. And so a couple of things I'm trying to focus on is to try to get people who are harried, maybe a little burned out, and to try to think before they talk. 'Cause a lot of times these complaints or misunderstandings between patients and families have to do with something that's said that maybe was meant to be a little glib or a little bit of a joke and it didn't come off right. And maybe if they slowed down and not said it in such a way, there wouldn't have been such a complaint and put people off on the wrong foot or something. So thinking before you talk, which is hard for some people, is something that I talk about in these coaching sessions. Another is that we have some colleagues, predominantly physicians, that, and this just kind of blows my mind, have really good patient sat scores, but we have a lot of complaints from office colleagues, referral docs, nurse colleagues. And I have trouble reconciling. I'm glad you're being nice to the patients, but why are you being an a-hole to our nurse or the referral doc's nurse? I mean, what's that all about? And I've had this on with more than one physician over the years. Some of whom are not here anymore, which is good. But again, it requires care and feeding with some. And I had a revelation during one of these coaching sessions. I said, okay, you're in the top 10% patient stats. Your patients like you. Your colleagues can't stand you. What's that all about? You've got enough insight to be nice to the patients. Treat your colleagues like they're patients. I know you can do it. Just do it. And coaching helps about half the time. And that's better than none of the time. And about half the time, people are resistant or that lack insight and don't get it. But that's one of the things that hopefully we'll continue to work on. And part of my new job is to continue doing that, not just with Prairie providers, but also other parts of the system. And of course, we'll be focusing on the low performers. So it won't be people around here. It'll be a lot of, there's some opportunity everywhere. The overall patient sat in the system on a roll-up is, with the 16 hospitals, is right around 60 percentile, which is better than half, but that doesn't sound too awful good. That's opportunity. And the good news is that's up from 30, 35 about 5-6 years ago. So it's getting better, and that's intentional and a lot of effort at the system level. And the system board has told Mary and the system leadership team. Mary started here as the CEO. This has got to get better. And you can look at patient sat and you can say, well, it wasn't as clean in the walkover as it could have been, and the parking is not what it should be, and you can make up a lot of excuses, but at the end of the day, in spite of those same factors, 30% of people are in the top 10%. So it can be done in an environment that's not perfect, and that's because our patients like us. So if you can make them like us, I think that's the key. It is harder in ER, because statistically, a couple of dings, it takes a lot of goods to overcome a couple of dings, statistically. Because the curve is not a normal shaped curve. The curve is a skewed curve, with most of the scores being up here. And that's a good thing, but that means the difference between a top 10%, top 20% score is one or two bad things. And then you can look at those monthly. We send the scores out monthly, but you need to index them for your purpose to look at your potential self-improvement. You need to index them to what the N is. If you got a really small N, it doesn't really tell a story. It takes about 30 surveys to become statistically significant, to really make much of a statement. Now, you can you can go by, the comments are helpful, and we compile all of those. We look at all the written comments. So we tabulate the written comments. We tabulate, obviously, all the phone calls. And then now we've got this whole Iris thing in terms of complaints to the Iris line, which the reason for that, it smacks of a big brother, and it's scary. And if you're on the other end of one of these Iris complaints, it's daunting. But from a process improvement standpoint, if you're a leader and you don't know what's going on, and you're not hearing about it, well, then you're not doing something to try to improve it. You can't improve everything, but if you don't know about something, you will not improve it. So the irises, and at the system level, and I've been looking at every iris for the last 2 weeks just as part of my new job, and there are about 100 a day complaints from the 18,000 employees on the system that rolls up to the quality division, and they're trying to make sense out of these, and it's fairly daunting. So we went from, and we may have overshot a little bit. We went from people didn't feel like they could complain, which is a problem, to people empowered to complain a lot. And we may have overshot a little bit as I read some of them, but some of them are really important. And I think where we need to be is somewhere in the middle, but we have swung way in it. So when I look at the 100 complaints, a lot of them dosing errors, a lot of them are caused by handoffs, as you might imagine, falls, and then we get fall reports from follow visitors. I mean, falls are big, particularly in the north where it's icy and they've had so much. I mean, it's and we self-insure, so those are all very important from a financial standpoint as well. But I don't get, thank God, I don't get a ton of ones about prairie employees. I really, relative to our volume and the rest of the system volume and the number of complaints, I'm thankful to say we don't get a ton of complaints. Now, we do get some complaints in high stress areas more often, like the CTOR, which you might imagine at the same time. One of the problems, and that, and I'd ask for your help to kind of help me with what I think may be part of the solution. For example, if a patient goes to the CTOR and has 8 hours of surgery, and it's tons of overtime, and everybody's tired, hot and fussy, gotta pee, patient nearly dies 5 times, and everybody thinks it could have gone better, right? Maybe it could have, maybe not. Patient barely makes it out of the OR and then walks home a week later. But nobody in the CTOR knows that because they're in the CTOR every day. We see these people on follow-up. We've somehow got to get them back in the loop. Remember that guy that Saturday night at the aneurysm? And we were all pissing and moaning, and the light burned out, and it was chaos. And that person made it home. I saw him in clinic. If you guys would help me do that, and I'm going to try to meet with them from time to time and catch them up on some of those good cases, because the bad cases, they can weigh you down, and they're heavy loads. And the kind of when the staff is not happy, the families they pick up on that, and then our patient satisfaction suffers because of that. So that's an opportunity. And so how can we help? We can help by getting back some of that feedback loop. If you have a particular case you're following up on in clinic, as we would, if we can, we have Prairie Praise, and I think that's been a good thing. And maybe we should get some of those positive case stories back to our CTOR staff members. I think that might help with some of that. The CMA thing I've studied a lot because in terms of facilitators and helping the clinic and pre and post load and things like that, we have really had a challenge in retaining these colleagues. As it turns out, I think we've done exit interviews and we've worked on it, and I think there are a lot of issues involved in this. It's not just one thing. I think the CMAs. I thought the answer that I was going to bring today, and as it turns out, I don't think it is, but I was thinking, well, maybe we ought to just have an arm and have a technical school through St. John's or St. John's Nursing and train them ourselves. And I thought, we could do that, just like Shar and others were a big part of getting NP training at St. John's. When you'll recall, 7, 8 years ago, there was such a horrible shortage of APPs, and that was a good strategy, and that was a good thing to do. It takes 9 months. So the CMA thing, the technical training, it takes about 9 months for them to be certified, and then we hire them, and then we have a period of time when we train them. But somehow, I don't know what they're doing that 9 months. It could be improved, and I think somehow we have to think and work together and be part of that process to try to improve their quality of care, whether it's taking blood pressures with them or openly thinking about a case, when you can, in a positive way in front of the patient. Maybe that will help. I guess I'd like to say that I'm willing to kind of own the whole, we're losing CMAs at a rate of 40%, right? Mm-hmm. I can own that when the normal turnover at Prairie is 9%. So we obviously have a problem, and you guys feel the problem because, we've still got, 8 slots open or whatever it is. So part of the problem is we get them, and they're not well trained, and we need to invest more time and effort into training them before we lose them. Because when they're not trained, not doing a good job, we yap at them, and they're unhappy, they're going to leave, and that's part of the problem. That's one part. Another part is there aren't enough of them, and the school somehow decided they hire a bunch of them, and there's been salary creep. So we'll have to adjust. We're going to adjust for that. Can we train more? I was pretty enthusiastic when I thought it was a 9-week program. When I realized it was a 9-month program, it was a little daunting. And then part of the turnover is also, so salaries apiece, not trained enough, feel bad in the environment, we didn't do enough to be nice to them, train them and keep them. Jobs everywhere, looking for them because there aren't enough of them. And then often they're a lot of them, which is a good thing, are people that are on a trajectory of personal improvement. So they may start out as a CMA and then become an LPN and then become an RN, and then and that's a good way to lose somebody as they continue to improve on what they want to do. But that's part of the seed that is CMAs, and so perhaps an anticipated turnover, if you did everything right, would be 20%, but it can't be 40%. The cost of the turnover is, from a business perspective, is huge. So we are working on that. I think we all, it would help for all of us to be part of the situation. Let's see, I wanted to mention the success of the Access Clinic, and many of you have helped, and that is really an amazing story. 330 Access patients last month, 330 just in Springfield. 60% of them were new patients to Prairie. 22% of them were patients with primaries from competing groups, MPS, Springfield Clinic, SIU. Then they just couldn't see him or wouldn't or whatever. Now there is a wouldn't part of that if they're Medicaid, but it's part of our mission, I'm just saying. It turns out that though, while of course there are some Medicaid patients, 50% of them have insurance. So it turns out that percentage of portion of Medicaid is mostly through the ER still. Eventually, that's something we want to try to fix. But the Access Clinic has been a huge success. Nasser has done a fabulous job of leading that, and we anticipate that concept continuing to grow. And many of you have helped, and that is really good. We really need to get to a point in Decatur where we can do it in Decatur because, and this I think is more than a rumor, but because a lot of the locals are talking about it in Decatur. Springfield Memorial is buying Decatur Memorial Hospital, which, and if the rumors are true, that's a really good thing for us in Decatur because as part of that kind of takeover, we think that they'll quit doing CT surgery in Decatur Memorial, which will put us on better footing, equal footing with St. Mary's, because we don't believe in small CT surgery programs, and they've no doubt done the math and realized that doing 50 pump runs a year is not something that you can likely in the long term run do in a high quality way. So I think that indirectly, if we could provide more access in Decatur, that's going to be a good strategy, and I think that'll really be a good growth story. That's kind of exciting. But you know, it's an interesting story. We're doing very well in the many of you go or know very well in the clinic in Jacksonville in otherwise inhospitable environment. Where most of the primary cares are employed by the competitor, and you'll like to see. So there's the Jacksonville where we have a nice clinic. Med group populates it, and we go as an outreach. The same thing we've done in Taylorville. The new Taylorville clinic is going to open, I think, in 2 weeks, something like that. It's going to be very nice. It's modeled after what was done in Jacksonville. It's worked out real well. Same contractor thing, but wonderful location, surface parking, and then we'll be using that model in other communities. I can't say yet, but having the med group put primary care in these areas, even when the hospital is owned by the competitor, and we still do pretty good. So we anticipate going more often to Taylorville. We have a lot of patients from Taylorville. We always did. Wes used to go there all the time. We have a lot of old patients from Taylorville. We'll be doing that with other, the Meyer Clinic, the med group doing the clinic, primary care clinic there in Meyer's been very successful. And you will anticipate us, the med group, doing that in other with other vendors in the near future, and that's a good strategy. So this whole concept of access, we indirectly benefit from the growth of primary care for the med group on that. Med group in central and southern Illinois is adding another 31 primary care providers this year. Largely they come like cardiologists in July. So, and then it takes a while to ramp up. We have 2 new VP docs coming to Springfield in July. We have interventionalist Herbert Caceres starting in Springfield in May 15th. He's just a fabulous guy. From Peru, where Cesar and Maria were from, and Luis. And Cesar went to medical school with him. He's a great guy. And then Jen Davis, who's a native Springfield interventional cardiologist now and knows a lot of people, is going to be starting on August 1st, I think. She's really, really nice. She's done numerous rotations with Gil and Shar, and you'll like her. So we've got some people coming to help, and then we need that because we actually are near the point where the access clinic is full, and we can't let it get so full we can't take new people. So we're cognizant of that. We want to continue to build that. Also, having many of you have helped in some of the outreach areas. That's been a giant success. I mean, you've got to say that we never lose when we go to the outlying communities and commune with the natives. And I often say, it's not the 10 patients I used to see in Clinton one morning a month. It was the other 6 days a week when, I was the face of cardiology in Clinton, and the ER doc would send them, whether I was here or not. I hoped I wasn't, but when I was, I'd field them. But if I wasn't, then other people would field them. And that's the outreach concept that we will continue, and I anticipate growing. Let's see. The seamless that Amy has been doing on the post-bypass patients and the alignment with the patient after they go home to improve their care and keep them from having to come back too often to clinic and come back too often to the ER is a great long-term strategy, whether it is post-CABG or post-MI or post-stent or heart failure. And so we're doing that now with post devices. It makes sense. I would continue on the post-CABG, working on the post-PCI. A lot more. It's harder to work and do that with 20 offices than it is than 2 or 3. But heart failure, and then we've identified through the system a need, as you might imagine, as we look at the metrics that the government uses to decide if you're going to get no Medicare cut, or 1% cut, or 2% cut, or 3% cut, based on a previous year's data. So we're in the previous year of next year where the system may, if we meet the metrics, get what they say they would pay us. If we don't meet those metrics, the system roll-up costs would be around $23 million. So we're chasing these metrics pretty hard. We're doing good in cardiology. One area of opportunity where we're a little worried about is indicator in COPD readmissions. And so we're trying to see if we can get the, we got the funding. I could get funding for that. It's just a matter of, do we have the personnel, to do it? Because there's a cost in personnel time to do it right. But and then you have to have buy-in. So if we can get a pulmonologist physician or team challenge, committed to the challenge indicator, we're going to try to put seamless to reduce readmissions for COPD patients, and that will be good. So that kind of more attention to care after they go home, the importance of that is not going to go away. It's only going to grow. As our compensation becomes not for how many times we do something, but one lump sum for one disease event. So in the future, we anticipate there'll be a lump sum paid for so much per MI. You got an MI? This is what you get. Medicare, split it however you want, but this is what you get. Make it work. An allowance, as it were, right? And we can do that, but where we're at risk is when they get readmitted. The readmission is expensive, or going to an extended care facility that's extraordinarily expensive. And so where we can reduce readmissions, where we can reduce need for going to an extended care facility, we can really save a lot. We're not going to save, the difference in cost between rosuvastatin and Lipitor. That's chicken feed compared to, a week in the sniff, So we recognize now that that's a weakness that we have. And continuing connection with those patients with your all's help through the things like Seamless it's going to grow. So this is what I lump all that to mean capitation. When you get lump sum payments, the different kind of lump sum payment, which is eventually coming, and I thought it would be here more by now, but that's where insurance contracts with the system entities to say, okay, we will pay. We have 10,000 lives under our Blue Cross Blue Shield Red plan or whatever, and we will pay you $100 per month per life covered. Spend it how you will, but don't come back asking for more money at the end of the year. So that is exactly, if I were, for the most part, obviously there are outliers, but if I were designing it and I wanted to reduce costs, I would press that. And you all are, and we're going to be a big part of that, because 40% of the care of that kind of stuff is cardiac. 40% of the care. So if you want to really impact the costs, you've got to include cardiovascular in the thought process. So that's an opportunity and a burden. It's an opportunity because we're going to continue to be important as insurance field changes, right? But we're going to be asked to do more, right? And that's good. I wanted to mention the cost of drugs. This came up last week, and it's symbolic of what is going to get worse. And I don't see an answer, and the government has not stepped in to help us yet. There's been all kinds of lip service, but so the new antidote for Eliquis, I cannot remember the name of it, just got approved. One shot of it, $50,000. $50,000. Now there's data that says it reverses the factor that Eliquis turns on. But there's no data that it's ever helped actually stop bleeding. So it's all test tube data, and it's FDA approved, and of course the drug reps are going to sell it like, please, it's malpractice, but Medicare won't pay for it. How many of our patients are going to be able to afford that? Should we stock it? How do we manage that? And the answer is, we talked about this, at the system level. I mean, you can look at it different ways, and then there's the way in the end, I think we're going to, for now, look at it. And so we're not going to stock it. We're not going to look at stocking it until they have some more clinical data, number one. Number two, they bring the price down, because that's just obscene. And number three, Medicare covers it. And so you say, whoa, you're going to ration care. It's very painful to make this, you know, you better stock this. And if we only used that for the few incidences of intracranial hemorrhage, if we didn't use it for bleeding groins or retroperitoneal bleed or some other bad but not necessarily life-threatening bleed, if we only use it for the system cost would be upwards of $7 million just for those few cases. And so, you know, where's the government on this? I'm sorry. This is just crazy. So we'll get data, we'll rethink. Think about the guidelines and where we might stock it and use it. But this is just the first of many of these biologics that are so obscenely expensive, and it's becoming a problem, a big problem. I don't mean to rant, but we draw lines, and so I drew you know, when we had to try to talk about this in the P&T committee, you know, I said, okay, well, we're used to not using devices that Medicare won't pay for, right? We're used to that, except on a study. But we've never really much said, no, you can't have that drug. We haven't really. But now we're going to have to apply the same kind of logic to $30,000 carotid stent or something. Follow guidelines. When it's indicated, use it, but not just put it in because you think it might help at that cost. And if Medicare won't cover it, you can anticipate it might help, but you don't know. And that's going to happen more often with biologics. So it's just a topic I wanted to put out there for you. Last Thursday, Amazon, and I didn't see this coming, Amazon got HIPAA approval for Alexas.
Alexa.
Now that is going to change.
It's Alexa.
Alexa. You're right. Good. Yes. I like that guy on the sorry, that live
Yes.
scan with it.
Yeah.
Alexa Silver.
I love that. So Alexa can be HIPAA compliant. And the way they crap on us for what seemingly it doesn't sound like that big of a deal, to thinking that your Alexa might go off in the room and God only knows who's in the kitchen with you at any one given time. I don't know. I'm just saying that the future, that's an example. The changes that are going to be made along that are going to be with Amazon, Berkshire, and J.P. Morgan. They've gone together to make a new medical group called Haven. And Atul Gawande is the CEO, and they're just getting started. But it's obvious that they're going to do a lot with Alexa, or that when they've gone through these steps. That I can't imagine who they had to pay off to get this done. That's just crazy, right? And so when Alexa is going to hear you cough or whatever, you know, they're going to prompt you. I mean, this is the future. It's cool in a way, but it's creepy in a way. So I'm just saying that it's obviously it's coming. Amazon has applied for 100 other patents within the past month to do that kind of chronic care management through other devices. It's just the same kind of thing we've been dabbling in. You know, they're getting into it in a big way. And so they obviously think that's the way to go in the future. And I think we should embrace it and learn about it. Frank Gary's working on a pilot.
So you just said.
He's working on a pilot, and we'll see. We'll see. So he's connected with an Amazon person. And we'd like to do something along those lines because I think ultimately, we're going to see more of that. And if used correctly, it could potentially help, I think.